Thumbs up. All right, so we're going to start the neuroendocrine tumor patient session. I'm going to be busy in the back of the room typing to all the places I typed earlier this morning to tell them to watch it live at a different URL. So if you're watching this, we're sorry for the technical difficulties, but we'll join you up. We have a really distinguished panel, and this session will cover really from the start of when you're diagnosed and the options available to you to how to understand what your imaging is about, to what are advances, and we talked about them earlier today with a little bit with Dr. Sunderland. But first up, I'm going to introduce Dr. Izat from the Princess Margaret Cancer Center. He's an endocrinologist and studies things of the endocrine system, but also works on NETs. He trained actually in the US at Cedars-Sinai, and it's a pleasure to have you here and give our Canadian friends, which are most of you in this room, a perspective on treating NETs in Canada, and then we'll move forward as well. With that.
Thank you. Thanks very much, Josh. I really appreciate the invitation. I was asked today specifically to talk about neuroendocrine tumors, and I hope that what we're going to discuss today is going to be a little bit more than what you already know. My job today is going to be to take you through what I call the good, the bad, and the ugly. You've heard a lot of the good, and my job is going to be to bring you to the reality and the gaps as they apply to therapies, and I will try as much as I can to get you to see the insights as to why we've actually not been doing a great job. Not how well we do it, but rather where the problems are. And the first thing that we have to contend with is we have to appreciate what it is that makes NETs grow, because if you look at imaging, you have to understand what you're looking at. Where did it start? Where is it now? Where is it likely to go? How will it affect the patient? Because you need to know what the drivers are that make this happen. How are we going to manage this if we don't understand how these things happen? And more importantly, how can we better harness the technologies and the science available to us to take it from the 20th century, which unfortunately is where this medicine is right now, into the 21st. And I hope that Richard will reinforce this as he tells you more. The first thing that we're going to dispel is the myth that this is a disease of the gut. And unfortunately, for many years, this area has been populated mostly by practitioners who know mostly the gut. And that's why carcinoid has always been the term used, and everybody had to have small bowel neuroendocrine tumors. Nothing beyond that. And that's a huge problem, because gastroenteropancreatic is, in fact, a portion of neuroendocrine tumors. And if you look at the data, and we've known this since the 2008s, and even more recently, you'll see the largest increases in neuroendocrine tumors are actually in the lung and in the rectum, not in the gastroenteropancreatic system. This is very, very important to appreciate. Part of that has to do with where did it all start? We know that embryologically, the endocrine system actually starts from the base of the brain in the pituitary, which is why the pituitary is actually the first and the highest neuroendocrine tumor, and now recognized by WHO as a PIT NET. And I was on that committee that actually allowed for the evidence to be presented to WHO to accept it. Going all the way down the throat and into the parafollicular cells of the thyroid, where we have MTC, another neuroendocrine tumor of the thyroid. And then down into the chest, into the thymus, and then into the lungs, into the bronchi, and further down the body. It's everywhere. And there are many other examples, lymphomas and sarcomas, and many other malignancies follow that paradigm, so this is not unusual. But most importantly, and what I want to show you with this slide, which probably, if this is the first time you've seen it, you don't know the details of it, don't feel badly, because your doctor probably doesn't know it either. The fact of the matter is we actually have these antibodies. We know that the neuroendocrine tumor is a family. And we like to know who the grandparents are, the great-grandparents, the children and the cousins, to be able to put it all together. And we have markers that tell us what that lineage is, so that when somebody pops with a disease in the liver, we can trace it back with better certainty that in fact it was from the rectum or from the ovaries that were removed a decade earlier, but nobody paid attention. Richard knows this. Hopefully a few more people will know that too. But the point is that we can actually do what's called lineage tracing. We can tell where that cancer started, where is it going, and what it's likely to do in terms of its progression. More importantly, we can also tell whether in fact it happens to have been inherited. There are some examples of that, and you'll see in a minute how that informs us on interpreting imaging. We have therapies, and we have the therapies that I've listed here. Almost all of them are known to you, and we have them in Canada and in the US from the top to the bottom. Surgery would be very good and be very, very, very nice if we were able to do this a priori. And that would be possible if, for example, we knew that somebody was genetically susceptible, because if we knew that they had a heritable condition, we can preemptively identify that individual and perform an operation to prevent a cancer. We do this in other areas, including breast, but we don't do it nearly as well in neuroendocrine, but it is possible. I'll show you examples of that. When a disease is no longer surgically curable, then we have to meddle with the disease. We gotta turn it into a chronic condition that the patient can live with. No longer curable, but manageable. And that's where the art and the science comes in, because you gotta play with the disease and its tempo. And if you don't understand that, then you're gonna be in trouble, because you're gonna end up paying the price with less returns. You don't want that. So that means that we gotta be able to exercise our options intelligently with knowledge. And it's not just G1, G2, G3. There's a lot more to that. We can deliver external beam radiation if you have a MET, but that's kind of late and it's not curative. We can deliver yttrium-90 to liver metastases available to us. We can do it here in Canada, finally, after many years. But as you all know, that's not curative. We have lutetium, and you're going to hear about it later on. We can do these things, but there are some restraints. And again, it has to do with your Ki-67, your gastroenteropancreatic, because the doctor has to fill that box as best as he or she can. We have medical therapies. We have medical therapies that span the biologics with somatostatin analogs, interferon, mTOR inhibitors, VEGF inhibitors, a whole bunch of drugs that allow the patient to be able to manage the disease in terms of its progression. And I'm going to give you a little bit of what I feel is the strength, but also the opportunities. And that's very important because, again, the imaging that you're looking at is meaningless unless you know where the patient was, is, and going. So the art here is knowing when to start, when to stop, when to switch over. Tailor the treatments so that the patient is not paying a big price. Can you get away with local versus systemic options? What are the short and long-range objectives? Risk-benefit mitigation. Are you going to turn off the bone marrow so that when you want to go in with lutetium, you've burnt your bridges? Not smart. Back in 2008, we knew about this. Even by that time, we actually already knew that we can stratify the disease, but unfortunately, we got stuck in this stratification, G1, G2, G3. In fact, the WHO didn't even recognize well-differentiated and poorly differentiated until much later. To this day, the lung group is still hesitating to accept neuroendocrine, even though it's a very large component of neuroendocrines. So for those of you who are involved in clinical trials here, I want you to pay attention. This is 20th century medicine. This is not acceptable. And the reason why it's not acceptable is there's a whole bunch of patients in that G2, G3 cusp. There's a lot of variability, so this is not the be-all, end-all. We knew from back in one of the first multi-center studies, started in Germany actually, that the amount of disease you have is very, very much an important determinant of how your disease is going to progress. We knew from that study that somatostatin analogs will reduce rate of progression, as shown on the left, with separation between placebo and the medication. But we also knew is that if you had a large amount of disease as shown on the right, you didn't do nearly as well, presumably everything else being the same. Then we started getting into a whole bunch of clinical trials which really tried as much as possible to address different parts of the gastroenteropancreatic system. And you can see them here with somatostatin analogs, lutetium, the everolimus, they're all there. The papers started to come out in very good journals. Almost all of them show pretty much the same type of curve, as you can see here, separating the blue from the red, where the proportion of patients who have disease progression is in fact held higher, meaning that the disease was slowed down. The disease is not eradicated. Patients do not live longer. Most of these trials were fatally flawed by one thing. They didn't really know what they were treating. They called them nets, and they called them well-differentiated nets. None of them defined what type of nets they were. If you look at the same issue later on, same year, same thing, same therapy, completely different pathway, almost the same results. Hazard ratio the same, the degree, the magnitude of slowing down the disease is exactly the same. And that makes you suspicious. Different therapy produces exactly the same thing. That kind of makes you suspicious, doesn't it? Just last year, another multi-kinase drug, a drug that pretty much targets a whole bunch of signaling pathways used in a variety of cancers, including kidney and bowel, pretty much showed the same thing. You can actually take the same patients who were treated with other kinases, and you can get a response. Cabozantinib. We can't get cabozantinib in Canada for those patients. If you have thyroid cancer, we can give it to you. If you have kidney cancer, we can give it to you. But God forbid somebody marks off neuroendocrine, we stop right there. That patient's reached a dead end. That's not good. Then we have the not so good part, which is something that people don't talk about. Why is it that these therapies are not very, very well tolerated? Side effects, off-target effects. This is what the patient has to pay, and I don't mean out of pocket. I'm talking about having ulcers, hands, foot, and mouth. Diabetes getting worse, feeling depleted, feeling poorly. Why does that happen? It happens because we interrupt pathways in the body that aren't just restricted in the cancer cells. They're in our skeletal system, the most important of which is blood supply to the skeletal muscles. No wonder people don't feel like doing things. They feel tired. Quality of life is impaired. Very few trials have actually come back to say to the patient, what would you rather do if you had the choice of having two treatments that will make you feel differently? One that will allow you to walk every single day, and one that will make you feel like you have to stay home all the time. Very important difference. Then we've got an area that really confuses the entire medical system, including lung specialists, as well as a lot of .NET patients. And that is called lung neuroendocrine neoplasms. And I use that term very carefully because I want to separate the two, and you need to know this. Neuroendocrine tumors are shown on the left. They are typical or atypical carcinoids. We now know that they occur in younger patients, no smoking history. We know the genetics, and we know that it's likely to be related to the genes that I've shown here on the left. But on the right-hand side are neuroendocrine carcinomas, which are divided into the large and small cell. We've got no therapy that helps these patients on the right. And large and small neuroendocrine carcinomas can occur everywhere in the body, and it's a very, very poor prognosis. And knowing the distinction between the two is hugely important. The genes are completely different. The pathways, but we have drugs that can target those other pathways. And there's a missed opportunity, a hugely missed opportunity. PET scans will not help you here. There are some neuroendocrine neoplasms that happen to be so tiny, they're under a centimeter, and we call them diffuse pulmonary neuroendocrine cell hyperplasias, or DIPNECs. I've seen patients where multiple lung resections have been performed because the diagnosis was not made. Huge missed opportunity because the person who's managing them does not have a full understanding of neuroendocrine diseases. Then we have heritable conditions. something that often is not talked about. And when you're looking at somebody's PET scan and you see multiple tumors, multiple areas that are picking up, you got to ask yourself, if you're reasonably honest, do these represent metastases, or do they reflect multiple different primaries because there's an underlying pitting of a genetic disorder that was not known to the patient and their physicians? Multiple endocrine neoplasias, von Hippel-Lindau, Lynch, Birt-Hogg-Dubé. Most oncologists never even heard of some of these. That's bad. Because if you pick up a VHL, you know that that person is going to be at risk of becoming blind, having a stroke, having paralysis because they have other lesions in their spine that will be called metastases that reflect different hemangioblastomas of the spine. And that's important because we know what causes this condition, and we have an antibody, we have a drug that targets this pathway very effectively in this genetic disorder, including pancreatic neuroendocrine tumors, which sometimes are not recognized as being part of that heritable condition. This is an intelligent form of treatment that identifies the underpinnings of a disease rather than going back to the 20th century medicine. Huge difference. I don't know how many of you here have had knowledge of pheo and paragangliomas, but this is a huge problem because many such patients present with neurologic disorders. They have lesions throughout their spine. They light up like a Christmas tree on a PET scan. FDG, gallium-68, MIBG, often recognized as metastatic disease, which is probably wrong. Many of these patients actually have multiple paragangliomas just in the epidural space, in the ganglia, not invading bony cortex. Huge difference. We published this several years ago, trying to explain to people that these are heritable conditions. There's at least 25 different genes now responsible for the pheoparagangliomas. Why is that important? This is autosomal dominant. You can determine that the next family member is potentially at risk. You can do something about it. Then we can talk about curative therapies, not retrograde reactive therapies. There's another area of medicine that we haven't taken advantage of. Chemo sometimes is important, but we rarely actually take that deep drive to determine who's going to respond to chemo. This is a paper that was published just a couple of years ago and attempted to do this by using combination CAPTEM in patients. And you all know about this because when all of the therapies that we have, including PRT, fail, we talk about CAPTEM. But what this paper did is they used a subset of patients where they start to look at the molecular signature and look at methylation of one of the genes called MGMT. And what you can see here is that if you happen to have had methylation of the gene, 6 out of 7 responded to the therapy, as compared to when it was negative, only 1 out of 7. This was one of the first few attempts in one of the major oncology journals that only just recently started to look at the molecular ability of pathways prediction to the response to treatment. That's not very good. If you had breast cancer, prostate cancer, or lung cancer in the 21st century, you would not accept that. You're going to hear a lot more about PRT, and PRT is great, and you're going to hear about a lot of the useful things that it's able to do as a means of chaperoning, and there are many other examples. Unfortunately, in Canada, we have gallium-68, it's available. We have FDG, it's available, but we don't have F-DOPA easily accessible, or some of the other methionine and many others that we sometimes to other institutions to get them done. The last thing that I want to end with is how do we measure the effectiveness of treatment? We often have these curves that you've seen it over and over again. They begin to look exactly the same. There's a recent debate that came up on, and you can look at the reference here, as to whether progression-free survival is really an adequate metric. And we haven't really addressed this for a long time. There may, in fact, be an inherent bias in what this measures, because at the end of the day, most of the studies that show an impact on progression-free survival do not show an improvement in survival, or quality of life for that matter, or quality of life saved per year, these are important metrics. We don't talk about it in this space. So I'm going to end by indicating that I think there's been some significant progress, and we've done well compared to about 20 years ago. Canada is finally getting closer to where Europe was 10 years ago, so we're a little bit behind. So is the US, by the way. We should be at the forefront. We have the technology. We should be able to do it, but there hasn't been enough of a push, I think. the progress has not been mechanistically driven, and that's a huge missed opportunity. For those who design clinical trials, unfortunately, there hasn't been an intelligent use of the capabilities of what we can do. I think that the future holds promise, and there are some very specific things that I want to mention. Head-to-head comparisons, rather than using controls that are totally inappropriate. Gallium-68 positivity is wonderful, but what about the patients who don't have gallium-68 positivity? There's a whole bunch of these, especially in the lung world. What are we going to do with these patients? There are also all sorts of things that you probably heard about in this meeting, and that is whether the beta emission, which is what the lutetium delivers, is really the sufficient therapy. Maybe we should be using something else that's a little bit more active, maybe other carriers. The idea here is to use combination of toxins that will go in addition to radiation to be able to target treatment. The point is, there's an awful lot that science and technology offers, which unfortunately has not trickled down into the neuroendocrine space, and I'm hoping that the next time we talk here, we will have finally arrived in the 21st century. Thank you so much for your attention.
So we're going to hold questions to the end so that they can be answered by our panel. The next up is Dr. Elshan Zan, who is actually starting a new job tomorrow at what time? 8 a.m. at the Cleveland Clinic. So she's here to talk about imaging and specifically nuclear imaging, but overall imaging as well, so we can understand how we are scanned and imaged. Dr. Zan.
Thank you. Thanks, Josh. Thanks, everyone. And thanks for joining us at this session. Okay. Do you hear me well? Okay. All right, as my talk is being uploaded, thanks for joining us. I'm a nuclear medicine physician and a radiologist. Most of the time, I'm not the physician interacting with the patients up front, but becoming more involved in the theranostic space. Now, I do see patients in my clinic. But what I do most of the time is imaging people's bodies. And I'm not sure if this is working.
There you go.
All right.
Just this one here.
Thank you. These were okay, so the objectives. First of all, let's see how a patient ends up in our diagnostic suites. There are no dedicated or no specific clinical characteristics of neuroendocrine tumor patients to present with. Most of the time, they come with multiple frequent abdominal pains, sometimes even headaches, all sorts of different clinical findings that are not specifically related to neuroendocrine tumors, but at the same time, sometimes they can just come with trauma to ER and end up leaving the ER by being diagnosed with neuroendocrine tumor. Because CT and MR are the workforce in our clinic for imaging any type of disease, and for the neuroendocrine tumor, we do a special imaging modality called the PET scans, as was alluded in the prior. But I will start with going over CT and MRI findings, because this is the most common radiological technique, and now we will switch to PET scans. So the basic fundamental difference between an anatomic and PET imaging. Anatomic represents radiology. All is included: X-ray, ultrasound, MR, CT. And for PET, it's mostly taken care of by the nuclear medicine physicians. In anatomy, we focus on a single organ. If you have headache, we do a head CT or brain MRI. If you have chest pain, we can check your heart, or we can do a chest CT. If you come with abdominal pain, we can do different types of studies, but we focus on your abdomen. What is going on with the liver, small bowel, large bowel, kidneys, right? Is the solid organs healthy in the abdominal cavity? If you have back pain, right, we specifically image your spinal column. This is all anatomical imaging. There is an external source in the setting of CT, We use X-rays, we shine them through the body, and create those images. So the patient is the passive image maker, so to say. We reflect the X-ray, and I collect the photons on the other side. We put the patients in an MRI scanner, right? We create radio frequency, we disturb the protons in the body, and then we image the body part. But MRI, CT, and ultrasound, these are all focusing on an organ disease. We need to know which organ we are imaging. As opposed to PET scan, it's a total whole body, not total body, but whole body PET imaging. And patients themselves are the emitters of the diagnostic properties. We image the patients, we tell them to sit quietly in a dark room most of the time, or a dim lit room, and then we, after a certain amount of time, which is usually 1 hour, we image the patients in a PET scanner. We start from, most of the time, head and go down to the mid-thighs, and sometimes from head to toe, depending on what we are imaging. If it's a melanoma patient, we go from head to bottom, head to toe. So PET scan involves radiation from the radiopharmaceuticals we use and from the CT component if it's a PET CT. But still, the amount of radiation given is barely equal to the amount of radiation given by a CT scan looking for the abdominal abnormalities. MRI does not have X-rays. It has only radio frequency, and it is radiation free. So we can do multiple times MRIs, but we're not so free for doing frequent CT scans. And for the PET CT scans, we try to eliminate it to the maximal extent. If we don't need to, we don't do PET CT scans. But again, the amount of radiation that most of the time we get asked from the patients is not ionizing. It's not gonna create, even if it's cumulative, it's not gonna create a meaningful effect that will harm the patient's bodies or that will create cancer, right? Because as a patient, no one would like to have a visit to an imaging center where, with the fear of, well, I had developed a second cancer, so that's a worry. In those patients, as much as we try to stick with the guidelines, which are dictated by NCCN, but sometimes we, in the United States, it's where I practice, sometimes the patients come to us with specific requests. I do not want to get a PET CT scan. I want a PET MRI scan, which is understandable. So we give a fight with the insurance companies, because at this point, if there's an indication to do a liver imaging study and a PET scan, sure, go with the PET MRI if it's available in that imaging setting, in that diagnostic institution. One other thing, the contrast issue. Most of the time, the patients get contrast-enhanced CT or MRI studies, and they always want to know why. So the contrast is a passive way of imaging the disease, the tumor cells in the body. As you can see here in the picture, I don't know if I have, okay, I don't have a pointer, but for the CT or MRI, when we give contrast, contrast leaks out from the unhealthy vessels. Most of the time in the tumor cells, the vessels are unhealthy, and when the contrast starts leaking out, it just highlights where the tumor cells reside, where the tumor mass is residing. So this way, the radiologist reading the scan can understand when they're looking at the image better. If there's contrast enhancement, it's going to look a little bit brighter compared to the background, and then you'll be able to pick up the tumor better. Do we have to have contrast for CT? Unfortunately, most of the time, yes. But when we do MRI, we try to be very mindful how we can minimize the contrast, or sometimes we even omit the contrast. But this is passive way of imaging any tumor. And now, since our talk and our focus is on neuroendocrine tumors, the PET scan is a more targeted way of imaging the diseased state of neuroendocrine tumors, because in PET scans, we do have very intelligently designed molecules that know a typical receptor in the body, somatostatin receptor type 2 being in this, that know how to find that receptor residing on the tumor cells. So we have higher specificity, higher sensitivity. And that's why neuroendocrine tumor right now is almost equal. When a patient gets diagnosed with neuroendocrine tumor, excluding lung, excluding head and neck, is almost equal to prescribing them, okay, we're going to scan you with the Dorotate PET CT scan. because as you can see here, it is a targeted way of understanding the diseased state. Has it been local in where it has been diagnosed? Has it spread out to the liver, to bones, to the lungs? We need to screen the entire body, and the best way to do that is a PET CT scan. We use dotatate PET because it's the best agent that can target, find the receptors expressed by this disease. And let's study some scans. I'm pretty sure you've seen at least your scans, CTs and MRs, and I will try to simplify how to look for your CTs and MRs for abnormal findings. That's an 80-year-old woman that presented with abdominal pain. It was just blunt abdominal pain that has been occurring in the last few months. She showed up at the ER. At the age of 80, when there's abdominal pain, we are very careful about not to miss any surgically curable diseases like small bowel obstruction or gallstone or kidney stone. But in that patient, the liver was healthy, kidneys were healthy, everything seemed to be healthy except the pancreas. Despite the fact our topic here is neuroendocrine tumor, this is a more aggressive disease. The large circle identifies a very ill-defined, minimally contrast-enhancing lesion in the pancreas. Pathology showed us that this was pancreas adenocarcinoma. But at the same time, the arrow shows a super bright spot at the tail of the pancreas. And this is by imaging characteristics. It is not pancreas adenocarcinoma, but it's typical for neuroendocrine tumor. In this patient, at the age of 80, she had a healthy life until she developed this vague abdominal pain. We end up diagnosing, right, the pancreas adenocarcinoma more aggressive, but at the same time, what contrast is showing us is pancreatic tail lesion, again, pathology proven neuroendocrine tumor. So we can see multiple pathologies in the patients, and specifically in the elderly population, we are very careful not to miss, not to be blinded when we diagnose with one lesion and miss the others. And speaking of the pancreatic tail, the arrows are showing in a 57-year-old patient, again presenting with abdominal pain, and it's very questionable whether these 1 centimeter tumors are related directly to abdominal pain, but most of the time, this is how these patients are being diagnosed if the tumor is not, doesn't have secretory features. What you're seeing, the arrows are highlighting a 1 centimeter mass at the pancreatic tail. As you can appreciate, it enhances very robustly, but this is an MRI scan. This is not a CT scan. And on MR, if you ever had an MR, it's a lengthy procedure. And you hear lots of noise, start, stop, start, stop. You wonder what we're doing, right? So we keep scanning, because MR and CT are scanning the organs, not the entire body. We keep scanning the same organ over and over with different sequences. It's a technical detail, but what you need to know is, because when we see a lesion as we see on the left-hand side, it could still be a metastasis, it could still be a neuroendocrine tumor. We try to take different pictures to increase our confidence in calling a metastasis versus not. And in this patient, what you see on the right-hand side is a super bright structure. It's again, another technical detail, but when the structures are so super bright, at least it's reassuring that they're not metastases. We still cannot be 100% sure calling it neuroendocrine tumor, but these features, at least from our experience, has taught us that this is most likely neuroendocrine tumor, possibly not metastasis, among the patients, so that the patients, interventionists or surgeons can have a different conversation, right? Taking the patient to surgery or biopsy but thinking, oh, I'm going to figure out whether this matter or not, and then telling the patient, you have a high likelihood of neuroendocrine tumor versus metastasis is, at least psychologically, very different. So that's 2 different patients with very similar presentation, intense abdominal pain. These are both CT scans. On the left-hand side, they both have contrast on them. On the left-hand side is 56-year-old, comes with interception, meaning that the bowel segments, entangled bowel segments. On the right-hand side, you can see very dilated bowel loops. The patient has presented with bowel obstruction. So obstruction is a more concerning clinical state where we need to be very mindful from their time of presentation to ER to time to take into OR. As opposed to interception, we have a little bit more time, right, to deal with the patient's problems. But what you're seeing here is, I'm going to highlight it for you, right? Do you see a well-defined mass? We don't see a well-defined mass on the left-hand side. So it's very difficult to diagnose this from diagnostic image as neuroendocrine tumor only. This patient needs to go to surgery, or this patient needs to have an interventional procedure, and a biopsy needs to tell us what's going on. As opposed to right-hand side, we have this large mass that causes small bowel obstruction. There is no other liver, pancreas, or lymphadenopathy in the abdomen. So the likelihood of right-hand side patient being diagnosed as potential neuroendocrine tumor from imaging studies much higher than the other patient because we don't see a well-defined light bulb enhancing lesion. And these are very different conversations with the patients before taking them to OR. They both are treated with partial resection, but doing a partial resection thinking, oh, you may have an adenocarcinoma as opposed to neuroendocrine tumor is a very different discussion in terms of the expectations from the surgery. And now a more typical presentation. 47-year-old man presents with diarrhea. At least right now there is an increased awareness of neuroendocrine tumor and related symptoms. Diarrhea is definitely a red light, a red flag for us. And what you're seeing here is we're looking at this patient's abdomen CT. That is done with contrast, so why we need contrast, to be able to figure the large circle in the pancreas. This is the primary mass. But why we need contrast is not only that. Why we need contrast is highlighted by the arrow. The little fuzzy dot, white structure that you see in the liver is a metastasis. So if we do no contrast, it's very easy to pick up the mass in the pancreas. But if we do no contrast, we will never be able to pick up the finding in the liver. And that's why we need contrast. And because we can't, now the pancreatic mass gets biopsied, it turns out to be neuroendocrine tumor. And look at the CT, how much it was undercalling, right? It was only on the CT scan why we need multiple different types of studies, because CT can, from this picture, let's read it together. CT is telling us there is a primary in the pancreas and one lesion in liver. So patient gets the biopsy, tells us neuroendocrine tumor. We switch to MRI. At the multiple red arrows at the bottom shows 2 MRI sequences. MRI is telling us, wait a minute, it's not only one lesion in the liver, it is multiple lesions. And now, time to proceed with dotatate PET scan. What you see on dotatate is the large black spot is the pancreatic mass, and numerous liver spots are widespread liver metastases. So why do we need multiple studies? Because it's very difficult, sometimes it could be difficult, not all the time, but to have this conversation with the patients, because if you get a CT, why do I need an MRI? If you get an MRI, why do I need to do a PET scan? Because we have very different purposes of using these diagnostic modalities. We don't use them all the time, all 3 in one setting, but this comes with experience, and this comes with whether you end up seeing an oncologist, endocrinologist, or an ER doctor. And as it was alluded on the prior talk, MEM1 syndrome. Thankfully, right now in the United States, the insurance companies are allowing us to use dotatate PET for screening purposes for our patients diagnosed with MEM1. But this patient's initial presentation was this. On the left-hand side, we have a liver MRI. On the right-hand side, we have a contrast-enhanced CT. Do you see the lesion? Since we've been training our eyes, let me help you. This time, the lesion is a very small sub-centimeter finding that has led to biopsy and genetic analysis and ultimately counseling, MEM1. So this patient went to dotatate PET scan because, as I said, now we are able to get it through the insurance coverage. Thankfully, that was the only finding in the body. Why did we do dotatate PET? Not to be able to diagnose this pancreatic lesion, because we already have a biopsy confirmation, but to be able to screen the entire body, pituitary, parathyroid, retroperitoneal space, chest. So with dotatate PET, you can provide a reassuring conversation to the patients, telling that, yes, MEM1 is not the best scenario to have, but don't worry. we can screen you regularly, and at baseline, the only lesion you have is in the pancreas, and it's treatable. This patient is another one. This time, patient presents with bowel obstruction, abdominal pain, a very complex at the age of 48. At the age of 48, you don't expect to see a liver like this. On the left-hand side, we see multiple, let me help you to highlight them. On the left-hand side, we see multiple very fuzzy-looking lesions in the liver. This is not the typical neuroendocrine tumor finding, so the radiologist reading that scan will be very concerned about a more aggressive disease like carcinoma. But what we're seeing at the pancreatic tail is a fairly large mass, right? And this initial readout comes as pancreatic primary, most likely adenocarcinoma with diffuse liver metastases, because liver mets, which you're seeing here, are not light bulb, the bright structures that I've shown you on the prior images. This is a very atypical presentation. We still don't understand why, but on the other hand, patient, one of the liver lesions gets biopsied, neuroendocrine tumor, very atypical presentation. And then the patient gets a dotatate PET, as you can see, patient gets, the story is neuroendocrine tumor. Patient gets treated with long-acting octreotide. And soon after the therapy, what we're seeing here is, look at the pancreatic tail. Dotatate PET is done. Dotatate PET was done after the octreotide treatment. The liver has calmed down. We don't have much, the liver, enlarged liver, the sizes have shrunken down as well. The pancreatic tail mass is still showing uptake on the dotatate, but the liver has responded very nicely. And the true follow-up, as you can see months later, right? What you're seeing here is the pancreatic tail has atrophied, and the liver has completely calmed down. You don't see any of the lesions which you're seeing on the left-hand side of the image. That's a very unusual presentation of a patient with atypical liver lesions, but at the same time, a very unusual super response to long-acting octreotide. Despite we don't understand why it looked at baseline, it's great not to understand why the patient responded right in such a great way. We are still learning from these unicorn stories, so to say. That's another patient, as you can see, initial presentation, left-hand side, got dotatate PET because her intermittent abdominal discomfort was scanned with CT and MR, and at the end, she had increased 5-HIAA in the urine. So the indication was to rule out neuroendocrine tumor. We were not sure what the patient had. On the left-hand side, let me help you. There were, what you see as 3 red arrows, there were 3 small bowel lesions. Patient was taken to surgery. They come out, neuroendocrine tumor. We're happy, patient is happy. Few months later, she presents with recurrent abdominal pain. The discomfort persists. What you're seeing, we do CT, we do MR, nothing shows any lesion, liver is fine, no metastasis. What you're seeing on the follow-up dotatate PET is single lesion left behind. I don't want to say left behind because in the surgical field, right, at the time of the surgery, the surgeons need to be very conservative. They want to take the smallest length of bowel possible. This was left behind because it was probably in a different in a different location of the small bowel where it was outside resection margins. And now we are thinking whether we can use PET agents. There are long-lasting PET agents like copper-64 labeled agents, whether we can use them for intraoperative guidance. So we are learning from cases and we are using our tools to provide better service. That's the patient. Initial presentation was liver lesions. Biopsy shows neuroendocrine tumor. CT, MR was negative. But what you see here at baseline on the left-hand side, the circle shows the primary. So what dotatate is helping us demystifying the liver lesions that were shown on CT-MR without any accompanying primary. Look at the small bowel, right? It demystifies the primary. The primary comes out. Unfortunately, the patient progresses, as you see, multiple liver lesions show up. And what happens is we treat the patient with the Lutathera, as you know the drug's name. We achieve complete treatment response. So we're happy with this, and we want to achieve that treatment response in every patient possible, although it's not the case so far. And that patient has metastatic neuroendocrine tumor to the lungs with unknown primary. On the right-hand side, because it's a neuroendocrine tumor metastasis to the lungs with unknown primary, what we do is dotatate PET first. This is to show you sometimes your doctor will ask to get another PET scan with FDG. Why? Because as you can see here, the liver metastases and the lung metastases on dotatate, you cannot really see them. Dotatate is not showing them, but FDG PET is showing them. And what FDG PET is showing is a way more spread out metastatic disease state compared to dotatate. So if your doctor asks for a different type of PET scan, just have a conversation. Why? Because when you understand why, right, it makes a lot of sense to go through another imaging procedure. And that's, I want to, last two cases will be about, let's move up, as it was mentioned on the prior talk. In some patients, right now we are seeing more and more paraganglioma or neuroendocrine tumors of the head and neck, and that's a very typical presentation. 20-year-old patient presents with right neck swelling, and the first thing that comes to mind is a lymphadenopathy. They put the patient on antibiotics, swelling doesn't go away. We do a contrast-enhanced neck CT. As you can see here, there is a large mass, it's around 4 centimeters. It's right sitting at the carotid body between the arteries feeding the brain. And very typical picture for a carotid body tumor, carotid body paraganglioma. And as you can see here, right, because of her age, young age, and this finding, we were able to get the dotatate PET scan, as you see in the center. But by the time we got the dotatate PET scan, patient has showed up to a different doctor in the community. That doctor got an FDG PET scan. So when we did the dotatate, we didn't know that the patient had FDG. So what you see here is a lesion that is positive on both dotatate and FDG, which is not the most common scenario. Most of the time you see dotatate positivity, FDG called FDG negativity. But this patient, since this presentation was a coincidental presentation, just want to put it here. If you hear about carotid body masses, when the patients are requested to do FDG PET CT, let's be mindful and start with dotatate. Maybe we can eliminate the FDG PET portion. 36-year-old patient, hypertension. It's a very young age to have hypertension, and that's a very typical presentation for FEO. The neuroendocrine tumor of the adrenal gland has a specific name. And it's a large mass. Everybody will definitely be able to pick it up from the imaging. This on the left-hand side, it's a fused image from a dotatate PET MRI. As I said, we try to use PET MRI in our younger patients as much as possible. And the mass came out, patient's hypertension has resolved. So CT and MRI are commonly used in the ER settings for trauma, abdominal pain, not feeling well. And when we see these incidental findings, if they look more typical of neuroendocrine tumor, most of the time they go to surgery. If not, we do dotatate PET to understand whether there's uptake or not. When there's uptake, the patients are staged and managed properly. And molecular PET, the most common reason for using molecular PET is young patients, unexpected findings, unexpected locations of the neuroendocrine tumors, but at the same time, picking up the patient population that will be benefiting to the max from the therapies, peptide receptor radioligand therapies or radioligand therapies known as, at the moment, Lutathera, targeting the same receptor. Thank you very much for listening, and that was all about it.
Last but not least, I'd like to introduce Dr. Richard Baum, Professor Dr. Richard Baum from Germany. It was actually in Toronto at a CNET conference in 2008 that I first met Dr. Baum, so thank you CNET's Canada for holding the conference and inviting an international crew as we have today. We're going to talk about the future, which means a lot of the things we're going to talk about may or may not ever become available in North America, but they're available in certain areas for compassionate care, so please take that into account. And without further ado, Professor Dr. Richard Baum.
how it works? Okay, thank you, Josh, for this kind introduction. I was many times here in Canada, and it's a pleasure after a long break caused by COVID to be here again. So the title of my talk is Past, Present and Future of Theranostics, and I will mostly concentrate actually on the future. These are my disclosures. I do not have any conflict of interest. This is a patient day, and I want to start with one of my very first patients I treated back in 1984, 40 years ago. It's a young child with a neuroblastoma. And you can see, I don't know if this pointer now is not working, you can see that this patient had a lot of bone metastases and a lot of pain. And we infused her with MIBG, iodine-131 MIBG. And you see that the patient during the infusion is eating and actually enjoying life because the pain nearly immediately disappeared after starting the infusion. And that made a very big impression on me as a doctor, that you have so or no side effects by a treatment, and that there are immediate positive effects on the symptoms. The next event is 30 years ago, which was actually the invention of DOTA-TOC, which is used for imaging and therapy of neuroendocrine tumors. And this was done by my friend Helmut Mecke in Basel in Switzerland. And you see that this agent is carrying what we call DOTA, that is a little cage, and this can take up the imaging radioisotope or the therapeutic radioisotope. And this dates back to 1997 and is the first patient I treated with a neuroendocrine tumor, and he had a paraganglioma. You heard already in the first talk and by Elsin. And this patient had also MIBG therapy and responded wonderfully, but then had a terrible recurrence of the disease with, as you can see here, bone metastases, which a broken arm, and he was actually needing morphine because of the very heavy pain he had. And he wanted to give up, and he said, I only want to die after the chemotherapy he had received, and which failed terribly. And then we treated him with yttrium-90 DOTA-TOC, which was actually produced in Basel by Helmut Mecke and put on a train to Frankfurt University. And I picked it up personally at the train station and brought it to the hospital and injected the patient. And he did not live only 6 months. That was a prognosis by the oncologist. But as you can see here, in the year 2000, 3 years after starting the treatment, he was still alive, but was not able to walk because he had a metastasis in the spine, which caused paraplegia, so he could not move his legs anymore. And then we treated him intra-arterially directly into this metastasis. And 3 years later, so 6 years after starting the treatment, he was even able to play soccer again, which is very, very important. That's a picture of him for a German boy. And that also put a very big impression on me as a doctor, what you can achieve by what we call radioligand or radiopeptide therapy. And this dates back 20 years ago. So radiotheranostics is actually a combination of a diagnostic tool that helps to define the right therapeutic tool for a specific disease. So in short, we can say see it and treat it. So we can select the right patient for the right treatment. And the principle, and I'm very happy to see Barbara Hertz here, the daughter of Saul Hertz, who actually introduced this principle of theranostic using radioiodine for treatment of thyroid, benign and cancer disease. So radiomolecular precision medicine is part of what we call personalized medicine, and means the right treatment for the right patient at the right time. That was also stressed in the first talk, that this is very, very important to determine the sequence of the treatments and to give the right treatment at the right time and the right dose, the right dosage which we can determine. This explains very shortly the principle which is called the key lock principle. So on the tumor cell we have locks, and these can be different targets. In neuroendocrine tumors, mostly GCPR-coupled receptors, a Nobel Prize in chemistry for the detection of this GCPR. And one of these GCPRs is what we call somatostatin receptor, which consists actually of 5 different subtypes. And then we are using the key which fits into the lock. And it really goes only in this lock, like in your house door lock, not neighbor's lock or, not normal cells, mostly not, but really only going to the tumor. And these are regulatory peptides, and then we have a linker and this little cage, the chelator, the DOTA, which carries the radioisotope, mostly gallium, but also isotopes mentioned here like copper, into the tumor, or in the same cage with the same key, we are using it for cytotoxic therapy. So we kill cancer cells by using alpha emitters like lutetium or yttrium, beta emitters or alpha emitters like actinium and lead mentioned here, or in future even Auger emitters like terbium. So this has come a long way, and I will not go into detail because you heard already a lot about it, which went from approval of imaging compounds like DOTA-TOC or DOTA-TATE to therapeutic trials published in the New England Journal and showing the advantage over existing therapies. And I will speak very shortly today about new developments with so-called antagonists and alpha radioligand therapy, or ART, and the Auger emitters and terbium and PRT of well-differentiated G3 I will touch also. So these antagonists, everything in life is positive and negative, or stimulation and inhibition, or like the Chinese say, Jing-Jiang. And this is also true for the endocrine system. So there are always stimulators, which we call agonists, and inhibitors, which we call antagonists. And very surprisingly, in neuroendocrine tumors, the agonists are more present on tumor cells, though there is a higher number of these binding sites in the tumor cells than the agonists. And this is shown here by a method called autoradiography, where you take a radioiodine labeled small peptide and make the tumor cells black. So as more black you see here, as more binding sites in the tumor. And by the way, this was how radiopeptide therapy was invented by Krenning when he heard about radioiodine on tumor cells, why we don't take, instead of iodine-125, iodine-131 or iodine-123. And this was the very first publication labeling somatostatin analogs. like octreotide with iodine 123. And iodine was the first agent used for imaging, published in Lancet in 1900, I think 84 or something, a long time ago. And then we can use this end agonist also for imaging, for PET. And you see here a very nice comparison between DOTA-TOC, which is mostly used in Europe for imaging neuroendocrine tumors. It's very similar to DOTA-TATE. And an agent called JR11, which is an end agonist. And just looking at the images, again, the black as more binding sites in the tumor. And you see immediately that with the end agonist there is higher binding in this very huge, more than 20 centimeter large pancreatic neuroendocrine tumor. But what you can also see that you can recognize a small liver metastasis hardly be seen on the DOTA-TOC, on the agonist PET-CT. So this was the first study I performed in 2012. And this is now novel agents, novel end agonists we are using called, for example, LM3. LM3, shows more lesions in the liver, as you can recognize on the right image, and these are not seen or hardly seen on the DOTA-TOC, and giving you a better contrast for the images. And another example is shown here, imaging bone metastases on the left with the agonist, and on the right, some days later, with the end agonist. And you easily can recognize that there are many more metastases in the bone recognized by the end agonist. Now, is that important? If you recognize 20 or 30 or 40 metastases? Yes, it is important, because for follow-up or for selecting the right therapy, you remember, the right therapy at the right time. So if you would take DOTA-TOC for treatment in this case, or DOTA-TATE, you would miss a number of lesions you can already target with the end agonist. So imaging is leading us the right way to the right therapy. And just to show you some very novel developments with a data, which is a cage keeping the imaging or therapeutic radioisotope for the key, you remember? And the data has the advantage that it can be prepared very easily. For the TOC, you need, a chemist to do it or a machine to do it. And with the data, you just take it into a vial, you shake and bake it, how we say it. It's the instant kit method to label it. So specifically for countries not so far developed like United States or Europe, and having not the infrastructure, to engage radiochemists and so on, this is a very, very interesting method, because it can be prepared within a minute or 2 minutes and gives you the same results. And the images are really stunning. If you look at this data, LM4, PET-CT, you see there is very little, if any, background. So you have very high contrast in your images. You can easily recognize metastases, like here, for example, in the liver. And this is something for Elsen, the gold standard today is always thought CT or MRI, okay? But now PET-CT is really becoming, for some indications, the real gold standard, because we are seeing lesions making no anatomical alterations. For example, here in the bone, if you look at the sitting bone here, it looks completely normal. But if you look at the PET scan, you can recognize there is a very small metastasis, probably in the bone marrow, which you cannot see on the CT scan. And the same is true here for the cervical spine, where you see a number of lesions, none of them seen on CT scan. So as a patient, you should not be satisfied if your doctor is telling you, oh, we have done an MRI, we have done a CT scan, everything is fine, right? If you have symptoms or there are production of hormone causing symptoms, you should request a PET-CT to get really the correct diagnosis. This is a relatively rare case of a patient with a breast metastasis of a neuroendocrine tumor, and the lady had an MR mammography done a few days before, and even on MR mammography, they did not detect these lesions, but knowing the PET-CT scan, they said after it, oh, maybe there is something. Okay, so the advantage is that you can recognize, as you see on the right inferior image, very, very tiny lesions, but very easily, even a child would recognize this. And then you can use, of course, these agents not only for imaging, but also for therapy. And we published the first trial on using antagonists. And this is something for the scientists, but it just shows you by dosimetry, by measuring the dose in tumor lesions, for example, in lymph node metastases or in bone and liver metastases, that you can get a higher dosage, a higher dose, radiation dose to the tumors and to the metastases. And higher dose means higher efficacy. Actually, there is no cell which can become resistant to radiation if the radiation is high enough, right? If you give 300 gray, like your father did in thyroid cancer, you can cure disease. You can cure any kind of cancer if you give enough radiation to the cancer cell. It's not like all these biological or targeted therapies or immunotherapies where the patients become always resistant after some months or a year or so. Radiation can really kill, but it must be high enough. And this is our aim for the future, to get more radiation to these tumors. I will get over this and just show you this case of a patient with a pancreatic neuroendocrine tumor. And this is from our original report. So you see, nuclear, or how I call it, radiomolecular physicians are not, injectionists, like sometimes, in the United States, where people just inject the agent and then do not take care of patients. We are physicians, at least in Europe and in Germany, we try to do and take care of our patients. And for that, you must also take care of the history and the development of the disease. As you see here, the patient had operation, chemotherapy, immunotherapy, all kinds of experimental therapy, and finally failed because on the left side, you see a copper dotatate PET-CT made in Stanford University. And a few months later, the same patient received the LM4 PET in our institution. And you see the difference, right? It's not progression of the disease, it's just better recognition of the disease. And seeing 150 metastases in the liver versus maybe 20 metastases you see with a copper. And the patient had failed Lutathera therapy because he had received already 4 or 6 cycles, I'm not sure anymore. But then we treated with antagonist, as you can see here, 3 courses of treatment, and you see the regression of the disease, and on the far right, you see the final result. There was only 1 lesion actually left in the liver. Coming to alpha, the alpha radiation has the advantage of what we call a high LET, linear energy transfer. Though the impact, is if you look a boxing fight, there are chaps, right? Just mild hits, and then there is a final cut, right? And the alphas have much more impact and much more power than the beta. So if alpha hits the DNA, it's completely destroyed. We call it double strand break, right? It's like a neck fracture, dead. The cell cannot divide anymore, whereas the damage of the betas causing single strand breaks can be repaired. So the cells, every day your cells make billions of repairs, right? Though this is not a new mechanism, this is a very, very old mechanism for human mankind to survive, to repair. And these repair mechanisms can be broken by the alphas, as shown here. And then we have also, the electron capture, for example, which hits not even the DNA, but hits only the cell membrane, okay? And this is what, for example, terbium can do, or also alpha emitters can do. Now, the first treatment was done by the German Cancer Research Center and became in 2012, so more than a decade ago already, the image of the year, showing that patients resistant to even yttrium-90, which is a very hard beta emitter, responded to intraarterial alpha therapy using bismuth 213, which is nothing for routine use because it's extremely expensive. One treatment is more than $50,000 just for the radioisotope because bismuth has a very, very short half-life. But it paved the way to use of actinium, which is an in vivo generator, actually, of an alpha emitter. And we have published a review for those interested just recently on the use of actinium DOTA-TOC for alpha therapy, showing that even in cases refractory to beta treatment with Lutathera or lutetium DOTA-TOC, in this case with a thymus carcinoma, neuroendocrine carcinoma, making a very extensive pleural carcinosis, there was a very nice response to actinium-225 DOTA-TOC. This is another patient showing you refractory to lutetium and responding very nicely to actinium. So we have many cases now, more than 200 actually, which I could show, where the beta did not work anymore. Like in this young patient from Norway with a lot of liver metastases, and despite DOTA-TATE treatment, I think he received overall 8 cycles of treatment in Uppsala, and he had a spread to the bone, as you can see, many bone metastases and many liver metastases. And then we treated him first with lutetium LM3 and then with actinium LM3, and you see the very significant remission of the disease, and the patient was even able to do sports again and jogging in the morning. And this is another dramatic case of a doctor from Sudan who came in, in a wheelchair because of the metastases in the spine and the pelvis and in the ribs and so on. He couldn't walk anymore. And he also had received, as you can see on the right side, all kind of treatments possible, including chemotherapy, and was progressive. And with actinium, he responded so well that he even could take up his practice as doctor again. So here at this Congress, we present the results of long-term observation of patients, and looking at adverse effects and reading the conclusion, you see that we not only improved the survival of these patients after having received treatment with the beta emitters, but that we had also very little adverse effects. In some patients, however, and this is how we call it idiosyncratic, that means nobody really knows the reason why some of the patients, a small number, have very significant toxicity in the bone marrow. But we are working on this to find it out. And just to show that not only our center has good results, but also centers in India, for example, using actinium DOTA-TOC and showing quite spectacular responses after failure of beta therapy. Very shortly, lead-212, which, as I heard this morning in the Henry Wagner lecture, was actually used for the first time, to study the in vivo biokinetics in plants, some 100 years ago. And we are now using lead-212 also for therapy, and there were results presented by Del Passon already at the Theranostic World Congress in Wiesbaden, which are organized in 2022. And you see that the lead-212 has a relatively short half-life of just 10.6 hours and decays to bismuth. And the bismuth is the agent really effective for killing the cancer cells. And this publication in the Journal of Nuclear Medicine described a series of patients treated with lead-212 dotamtate. So this is another chelator, another small cage holding the lead with a peptide. And you see there were some spectacular results, even in some patients, complete remissions. And this is quite encouraging, but needs to be, of course, confirmed in different center and larger series, which is ongoing and hopefully soon published. So the summary there was that there was in all of these patients some response and no significant adverse effects. And then terbium, what is called the Swiss Army knife of nuclear medicine, because we can use terbium for imaging, for PET imaging, for SPECT imaging. We can use it for therapy and even for alpha therapy with terbium-149, which can also be used for PET at the same time. And our group was the first to publish results on terbium-152, which is interesting because it has a long half-life of 17.5 hours, so it can be used for dosimetry or other clinical studies, which are very important. And I showed you this already, the Auger electron radiation therapy, or AERT, which is based on very high LET, which can destroy the tumor cell membrane and give additional effects aside from the other effects of the beta, which is also present. And we published, again, the first study in collaboration with a center located in Switzerland. As you can see here, there was a distance of more than 600 kilometers from the production site to the injection into the patient, but we were able to do that and got some very nice whole body images, but also SPECT-CT results, and I'm very grateful for the people, Christina Müller, for example, and Nick van der Meulen, who were essential in producing these radioisotopes for treatment. Now, future progress will happen mainly in 3 areas listed here. First, on the radioisotope itself. I have spoken about alpha and Auger emitters. Then on the radiopharmaceuticals, we will have new small molecules, how we call it, but even monoclonal antibodies are reconsidered for treatment using the so-called pre-targeting approach. And then for you as a patient, a major breakthrough will be these ultra-fast digital PET-CTs coming up now, where a total body PET takes just 2 or 3 seconds, not minutes, seconds. So you go in and out, and that was it. And you have a 3-dimensional image of the total body distribution. Of course, this can also be used to do what we call dynamic PET and get completely new insight into tumor biology. And there are different models, for example, from United Imaging, showing you here a dynamic PET-CT, or from Siemens, and I think GE is now also coming up. But also important, very important for the future, will be to have trained physicians, trained nurses, and knowledgeable patients. And within the ICPO, the International Centers of Precision Oncology, we are working on this using different experts in different areas listed here. And on the far right, you see the patient partnership and the nursing, which is very important. And you see the name of Josh Mailman and Linda Gardner here on the screen. They worked very hard to produce already content for this e-learning platform. And everybody of you listening at YouTube or here in the room is invited to participate in this. I would like to thank my team currently in Wiesbaden and the team at my previous place in Bad Berka for all the support over the years. I would like to thank many colleagues, but last not least, I would really like to thank also you as patients for successes, but also for failures, which encourage us to go forward and do new science and new technology for your benefit. Thank you very much.
We're running a little late, but we started a little late. There's a reception going on next door, but I think we'll use that little bit of time to take back up some of the questions you may have. We do have a couple of questions. I guess why don't you go the other side, Richard? We do have some questions that have come. Here, I'll sit with you so the camera can get all of us at once. Some questions that came from our YouTube audience, which I'll kick us off with. And if you have a question, raise your hand and a mic will come to you. But one of the questions that came in is, we talk about imaging and we talk about patient care, but how do you define progression? What is it, 10%, 20%, 30%? How do you, and over what time period? Elshin, I'll let you start and see if anyone else has an addition to that.
Very, very smart question, definitely, because we're dealing with the same issue, the definition of progression. When you look at the published guidelines, if a mass is larger by 25%, if it measures larger, it is defined as progression. But in neuroendocrine tumors, we're dealing with almost innumerable lesions in the liver, in the bones. From my perspective, when I read a scan, follow-up PET-CT scan, if I see a new lesion, this is the definition of progression. When the lesions, SUVs, measure a little bit higher, we don't know what that means, and it should not be interpreted as progression. But presence of a new lesion is progression. Presence of a new lesion in a different organ. Let's say if we are following liver and all of a sudden we see a lesion in lung, this is progression. But increasing SUVs should not be interpreted, in my opinion.
Over what time frame do you talk about?
The dotatate PET follow-ups are done typically over 6 months. So in 6 months, if I see a new lesion, it is considerable progression.
Of course, this depends all on which kind of tumor. And I think you made the really right comments, right? Neuroendocrine tumors is not one entity. is 80 different or 100 different entities from very slowly growing tumor, where a new lesion in the liver is not relevant at all. So you have not only to ask for the formal definition of a CT or MRI or PET, but you also have to look at your patient and ask, is the patient suffering from it? Is there a risk from this new lesion and so on? So progression needs to be defined in a clinical content, okay, and not only for formal, enlargement or not enlargement. And I can tell you, I had really 20 years discussions with the oncologist, saying, even if your MRI or CT is stable, and we see now bone metastasis, that is exactly what you mentioned, new lesions in different organs, then this is becoming relevant. And I think we are at the beginning of a revolution in 2024, because in future, AI will play a very, very important role in that area. We have already, algorithms which do what we call automatic segmentation. Though this software is reading a PET-CT scan in 30 seconds and finds out how many lesions are in bone, in liver, in lymph nodes, and so on, and give you very, very detailed information, not only there is one lesion more or not. And I think this is very much needed. As you have shown, in neuroendocrine tumors, there are patients having 50, 70, 80 lesions. Do you think any radiologist or nuclear medicine physician will sit down and count 1 hour every lesion for 5 different scans and so on? This is impossible. And this is where I think that, intelligent-based medicine, how I call it, AI, for theranostics, will play a very important role in the future and will give you much more detailed information. I think you also had a comment.
I do. And like Richard, although I hope that our intelligence is not going to be artificial, it's going to be natural. Let me give you an example. We grade toxicity on a score of 1 to 4. Yeah. When a patient reaches 3 to 4, we say, stop, can't go anymore. Progression, on the other hand, is measured as a yes or no. 20% by RECIST criteria on CT or MR. It's carved in stone. The FDA will only accept that when you're talking about any type of therapy. So all of the things that you've heard about from a functional standpoint, but beyond just simply the measurements and how accurate that millimeter is, at the end of the day, as Richard and I just want to add to that, it's really how it's going to affect the patient. Is it getting to the point where are we breaking away from this treatment, or are we going to be able to manage it in a way that allows for the patient to carry on? That, in my mind, that grading in the same way, and remember, it's always a benefit and a risk. If we're grading toxicity, we have to grade the efficacy, and it's a balance in the end.
So at the end, you treat patients, not tests or image.
It's not just the patient, but let me take it one step further. Sure. As I mentioned earlier, it's a journey. And it's not where I am now, but where the patient is going to be 5 and 10 years down the road. Somebody who is getting to the point where their heart is beginning to fail, and that may be the reason why your patient's liver shrank, by the way. That may very well have been the reason why the liver shrank, not because the treatment actually affected the liver, but rather the heart is now functioning properly. That's a patient response, and that's not a tumor response. So those are the kind of things that are often very difficult to be able to communicate if all you're doing is looking at CT and MRs, which unfortunately is necessary. And we sometimes in clinical trials have to get a whole bunch of centers to read the scans over and over again. We talk about the variation. But at the end, I think, and Richard said it quite nicely, we need a team of physicians who are actually able to look at the patient, between the nuclear medicine, between the clinician, between the patient, are able to actually come together. And I would argue that generally speaking, when it's working, you don't have to think so hard about it. And when it's not working, it's always the patient that recognizes that first and foremost.
So I want to bring up one other thing. aside from all of this. For those of you in the room who are taking pictures, that's great. But if you go to snmmi.org/PED, all these live streams are already recorded, and your screenshots from that will be much better. And for those of you who are online in our online audience, these are being DVR'd, so if you miss something, don't worry about it. You can just replay it. There's a lot of detail that went on in this last hour and a half, hour 40 minutes, so don't worry about it. It's there. I know this was a lot of information to absorb. I'm going to start with you, Dr. Ezra. One of the things we talk about is toxicity, and in nuclear medicine, some patients are afraid that after therapy, this may cause their tumors to get more aggressive if they weren't effectively killed off. And I don't think this is a phenomena that is that occurs that much, but I also don't think it happens just in nuclear medicine. So do you want to really discuss how do you discuss toxicities and or change in tumor behavior on the different treatments?
Okay, asking a whole lot of questions.
I know.
But that's okay.
Compound questions. I learned
I love it.
sentences in
Listen,
third grade.
I hope that my intelligence is not too artificial. But importantly, I think, again, we're asking pretty much the same question.
Yeah.
How do I know I'm making the right choice? That's really what we're asking, right? So at the end of the day, the question becomes, if you just hit a little bit, is that tumor going to hit back even harder? Is it going to start to engage a whole bunch of other pathways that are now going to make it even harder for me to go with another drug? And that's generally a problem that plagues what I call the electrical approach. The electrical approach is the drugs that we use. They're all having to look at differing wiring systems, trying to clip one, and then you get an overactivity of the other pathway, and so on and so forth. So that's really what Richard, and I hope many of you absorbed what he was saying, because he gave a splendid talk, and I really appreciate it, so thank you. What he's talking about is having to knock that enemy with a knockout, not just to provoke it, but to knock it out. So I don't think the idea is that it's necessarily that the radiation is going to make it necessarily worse. It's a question of, is it going to create an environment where you will have killed the innocent bystanders, the bone marrow? That's the biggest. So one of the things that we worry about, we haven't talked about it so far, and I'm interested in some of the other comments, is, for example, myelodysplasia. Some patients, we now recognize that if we give them PRRT, they develop myelodysplasia. We don't know whether it's the treatment itself or the prior exposure, but there are clearly some risk factors here. So that's the innocent standard. I would argue that most patients end up failing not so much because of the cancer, but rather because of the side effects that occur to the innocent bystanders. The liver becomes a huge problem. Many patients end up dying because of liver failure, and the others because of the bone marrow. So if we do the dosimetry that was talked about before, we can protect the innocent, then we can do a better job at killing the tumor. Richard?
I think I have to add something to your comments. First, we have data from over 4,400 treatments over 18 years, so it's a real big data pool on MDS, on myelodysplasia, and we found it in 2.6% of the patients. Now, if you look at a very established chemotherapy like carboplatin or 5-FU or many agents being around for 40 years now, right? The numbers are 5 to 8 to even 10%. So radiation is less toxic to the bone marrow than most chemotherapy, okay? That's a fact. And in chemotherapy, nobody was talking ever about MDS. It's only an issue brought up with radiopeptide therapy. Why? Politics? I don't know. Anyhow, so forget about MDS, I would say. If you have it, it's usually a very mild form of leukemia, which can also be treated, by the way, nowadays. Only a very few patients really have a very aggressive form of leukemia, which is deadly. So it's a very small risk, but there is no treatment without any risk, okay? And I think this is very small.
But
For
I
the,
think
for
it's
the
also,
liver, to correct you, for the liver, we did not find any significant toxicity. So one have to differentiate between progression in the liver, which causes, of course, bile obstruction, inflammation in the liver and damage of the liver, which is tumor progression. For that, you are completely right. But the radiation itself, with the yttrium-90 sears you mentioned, the radioembolization, you have liver damage of normal, but not with radiopeptide therapy.
but I think it's also important, certainly for patients evaluating therapy, to understand the risks of all their treatment options, just not one, and make sure they understand the entire set of risks comparable, so that they can make, as you said, these are benefit-risk trade-offs. And I know when you first met me in 2008 and you scanned me, you wouldn't treat me.
I was shocked.
Well, you wouldn't treat me in 2008 because you said, you're stable. I don't know why you're stable, but you're stable. The best I'm hoping is to get you stable, and you're going to have a point in your pathway, we all do, where things are going to change, and then we need to take that risk-benefit analysis. But it was like, you don't need to take this risk-benefit analysis. You don't need to take a risk when you don't need to take a risk. And when you need to take a risk, we can come back and talk, but this is not a time to take a risk. I know you
So
want to comment.
Josh, no, I just wanted to make sure that Richard and I are talking about the same thing. When I said about patients dying of liver failure, I did not imply that it was because of a PRT. What I'm talking about, Richard, is, and you may not be necessarily aware of this, is that when you have access to fewer therapies, especially in North America, people end up getting subjected to more surgeries, more embolizations, more radiofrequency ablations. So now you have an organ that's at greater risk, and when you hit that vulnerability at that point, which is exactly what you're trying to make, then you've curtailed and reduced your long-term outcome for that patient. That's what I was after.
Okay.
We have a couple questions. We're going to take like 2 from the audience, and then there's a reception next door, so we're going to go do that. And then there's a reception 5 p.m., so you're going to be receptioned out in a second, but with the mic.
Hello, thank you very much for those presentations. They were excellent. I have a question about the actinium-225. Are you seeing better results in specific types of neuroendocrine tumors than others?
In which kind of neuroendocrine?
Are you
Are you
seeing
seeing-
better results with actinium-225 in some tumors versus other tumors? Like,
Let's say GEP versus non-GEP.
or, PNET versus...
It's very difficult because, in that sense, I'm a real scientist. And for answering this question, one really needs randomized studies with a certain number of patients with statistical quality, comparing this. And this is extremely difficult in neuroendocrine tumors because they are so rare and patients are so different. As you very nicely showed, genetic differences, proliferation rate, and so on. I would say overall, alpha emitters, specifically actinium-225, is more effective than the beta emitters. We see that in prostate cancer. We see that with the FAP agent, I have treated now 20 different types of tumors, ovarian, colon, lung, and so on. And actinium seems to be more effective overall, okay? But if there are differences within different neuroendocrine tumors, I would say the most or the best efficacy is in rapidly growing neuroendocrine tumors, in G3, in well-differentiated G3 with high somatostatin receptor expression and the Ki67 of 30+%, but below 60. If it goes over 50, 60, you need chemo or any, real bomb to cut it down.
I'm going to take one last question. I think there was one more back there. Yeah.
Yes, excellent presentations. Thank you very much. You've given me a lot of hope. I have two, hopefully brief questions. One is I have metastatic pheochromocytoma with mixed avidity. So in my care center in Edmonton, I was told that I wouldn't be a candidate for lutetium. And the other question was, this does seem to be a bit of an art. When is it time, which I think you kind of alluded to with Josh, to intervene? The sort of plan for me was to wait until my spine was about to fracture and I was in great pain, and I knew I couldn't live like that, so I came to see Dr. Izzat. So, I guess that's my two questions.
I'm gonna, before you guys answer, can you answer the generalized yes and not a patient-specific? Because you're not licensed
I'm very
here.
sorry. Yeah, we should not discuss individual cases here, because to discuss really, I need all the details, much more information, which takes me probably 20 minutes to read and to dive in before really giving a correct answer, right? So in general, if I understood correctly, you have pheochromocytoma, right? Pheochromocytoma. Okay, I mean, one have to really look into what is the best from a radio ligand treatment. What is the best agent to treat you? Is it MIBG, which is a good choice? I showed you some cases back in the 80s or 90s of patients still alive, if it is a well-differentiated tumor. So MIBG is not, I think it's now available in the United States, or not anymore. It has been withdrawn. Yeah, unfortunately, because no profit for the companies, but anyhow, so you probably have to move to another country for that. I'm sorry to say, yes. But of course, also one can look into agonists and antagonists, right, with receptors. And there are a number of targeted therapies also which can be discussed, okay? Do you want to answer? Or?
Well, okay, I'm going to make just very broad statements. And that is, for example, MIBG therapy is available in Canada and I believe in the United States, but to a select few childhood onset neuroblastomas. So imagine if we have an adult who's diagnosed with neuroblastoma, we have to now negotiate with this sick children's hospital to be able to accept an adult, to be able to treat them, because only that hospital has access to that therapy. So go figure. These are the kind of things, but I think that's a very different topic. I'm sure Josh will agree to that.
It's probably actually a day-long session. And actually medical systems in general and how they work and what they approve and where things are available. And with that, I would like to close this session and thank everyone for coming. And thank you who are on the live stream for joining us. For those of you in the room, about 2 doors down? 1 door down, right next door, there's a reception with some food and some drinks if you like. There's also the Marshot reception in another half hour's time. Please feel free to join and network us in the room next door, and thank you so much. I know it's been a long day, but hopefully a fruitful day for all of you. And with that,